Okay. So
We
I
see it
have
now.
Dr. Andrea Anderloni and Alma assisting me. And now you see the distal esophagus with some past esophagitis. The patient's being on PPI and NG suction, but as soon as we get across the cardia, there's a lot of retained fluid along the greater curvature. And as we approach the pylorus, we see a widely open pylorus. This lady has advanced metastatic pancreatic adenocarcinoma. She had biliary obstruction that was treated at another center by external biliary drainage. And now she's having gastric outlet obstruction. And we are going to palliate that with EUS-guided gastroenterostomy. So back to my upper endoscopy. I'm using a regular gastroscope. If the patient is intubated, as in this case, you don't really need to aspirate everything. We did some suction because we had some time waiting to get on air, but now the airway is protected, and the best way to get rid of all this fluid in the stomach is by downstream outflow once we create the GJ. So this is the bulb. You see at the apex the extrinsic tumor stricture. I'm trying to wedge the tip of my gastroscope into the stricture so that cannulation with a guide wire is easy, right? As I push my gastroscope, the margin of the stricture begins to be seen. Now I'm gonna push a regular sphincterotomy through my working channel into the beginning of this stricture. So I'm pushing a preloaded sphincterotomy through the gastroscope working channel.
So Manolo, so far the technique is more or less the one that we were using more than 10 years ago for duodenal stent.
Exactly.
So far, nothing different.
So far, no other skills than those required to place a duodenal stent.
Okay.
So now you see the stricture. I'm pushing my sphincterotomy under endoscopic view. Now I want you to take a look at the fluoro. Do you have the fluoro screen as well?
Yes, we do.
Alma, can you push the wire? So you saw Alma nicely pushing the wire across the stricture. I'm pushing my sphincterotomy over the wire, and I want to go up to the triangle, which I don't know if I will be able to do, or the wire will look backwards. Can we angulate a little bit sideways? So you see, I'm pushing the sphincterotomy, and it's moving forward beyond the trites, right? The anatomy of, can you remove the wire, Alma? All the way to the tip of the sphincterotomy? Okay. Can you push forward? Can you? So even if my guide wire is looping backwards, I'm pushing my sphincterotomy, which is going forward. And I think we are past the trites, and I'm gonna remove it. You see on the fluoro, the air bubble of the stomach is overlapping the segment of jejunum where my guide wire is. So I'm going to exchange my wire with Alma. She's pushing the wire in. I'm removing my catheter. And so far, this is monitored by fluoro. So push the wire in, Alma. Keep going, keep going, keep going, keep going. Good, 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 good. So I remove the wire all the way. Now we have a nasobiliary drain ready, a standard commercially available. In this case, it will be a 7 French nasobiliary drain. We will push it over the wire. Can you show on the camera how their hands? So we just remove the sphincterotomy all the way. We take care to wet the guide wire. We have pre-flushed with saline the nasobiliary drain. And now maybe we need another set of hands to
I can help.
feed the wire through the lumen.
Okay. This is a 7 French stent that can pass easily through the channel of a diagnostic gastroscope.
So I'm assuming you all know why do we need a catheter past the duodenal stricture is for irrigation. We need to flood the small bowel beyond the stricture.
So we have two
We can
questions.
do it in the 3rd or 4th duodenum. We can do
Andrea?
it anywhere in the proximal jejunum.
Andrea, we have two questions from the audience. The first question goes, is there any difference having the patient in a prone position or supine or even lateral, left lateral? Do you prefer any position in these cases?
Opinions vary. I don't think if you put the patient supine, probably intubation is mandatory, right? Because the risk of aspiration is greater. We routinely do it left lateral, semi-prone, or complete left lateral. And some people feel that the pulling of the fluid in the duodenum is much better.
Okay.
So there's no consensus. If you want my honest answer, I don't think it really matters. As long as you carefully adhere to the procedure steps. So back to my procedure, I'm just removing the upper endoscope. So I'm pushing my nasobiliary drain. I keep an eye on the fluoro, trying to minimize the risk of dislodgement. And now we are going to exchange the gastroscope for the linear US scope.
I have a question, Dr.
Andrea.
Andrea.
Before your question, just the only thing we need to do that now is remove the guide wire, put the cap back on the catheter so we can generate high volume irrigation, and then reintroduce the endoscope alongside the nasobiliary catheter. Sorry, I cut you off.
You to show us on the screen how could you recognize the ligament of Treats as a landmark for your insertion of the nasojejunal tube?
How can I recognize?
Yes, yes. What's the landmark
Okay.
for the Treats ligament?
Did you understand why I took it out?
You know,
We have to do the exchange.
do you get the fluoro? I don't know
Yes.
if I can point to the fluoro.
Now,
But-
the oscilloscope. Yes, I can take it. Yes.
Ligament of Treitz is around here. It's here. So you have the bulb going down, up, and taking the first angle. It's around here, near the spine. It really, you also have EUS landmarks, which basically is the pancreas.
Great. So I'm
And
asking this question
Okay.
because during the EOS, we have to
I'll
puncture
take that question.
close to the ligament of treats to have a stabilized position for the gastrojejunostomy.
Manuel and Andrea.
Place the nasojejunal tube in order to allocate, and now we have the US image.
So this is a collapsed loop of small bowel. We know we have two landmarks. One is the nasobiliary catheter. The other is fluoroscopy. I don't know if you can get fluoroscopy. On the fluoro,
We don't have the floor, yeah. We
the,
don't have it.
you have it now, right?
Yeah, yes, yes.
The tip of my EUS scope is directly looking at the nasobiliary catheter at the triangle. You will have to trust me on this because we only have 5 minutes, so we can go a long way. But more important than taking my word for it, I give you the fluoro and the EUS, and I ask Alma to inject contrast.
Do you want to measure before
No.
in order to show the difference?
No, don't freeze.
Okay.
So, this is live EUS. Alma, please, can you put the contrast? Injecting fast. So the tip of my catheter is a little bit away. The contrast is coming distally. So what I'll do is pull back a little bit my catheter, inject. Now the contrast is flowing backwards. I'm gonna pull back the tip of my catheter a little bit towards myself. Can you inject some more contrast?
You need to
And
fill
now,
the segment close to the
on
treats
US,
ligament.
I've lost my positioning. I need to find myself again. But what I see on the fluoro is telling me that maybe I should be targeting a different loop. This is why I didn't intentionally, I tried to avoid putting contrast. Can I have a gauze, please? I tried to avoid injecting any contrast during the insertion of the nasobiliary drain. So now I have in front of me the half distended small bowel with the nasobiliary drain in it. So I have a vessel that I'm trying to avoid in my trajectory, a mesenteric vessel in the transverse mesocolon, right? So what I'll do now is, before I keep on injecting more fluid with a water pump, I will, now that I have a target, even if not fully distended, I will get my axios, my lamps in place before I start flooding the small bowel. So can I have the...
What kind of axios are you going to use for this procedure, Manolo? The bigger the better?
Well, in the past, we used to say that the bigger the better. Now, we've come to learn that there are problems that need to be fixed with a 20 millimeter diameter. Again, can I have a gauze, please?
It's very important that you lubricate with water the catheter, because the catheter is 10.8 French.
Can you lock it?
And this could have some friction, but in this way, everything is fine.
Dr.
we
Andrea, we have a question.
Yes.
If you want to fill
So,
the small
now-
bowel,
This is my half distended loop of bowel. I want to keep it inside. I want to give you, I'm going to give you also the fluoro because sometimes it's not what it is. The anatomy is very,
You are removing the...
yeah, I know,
Okay?
I know. So as I try to reposition myself,
Okay.
my drain came slightly backwards. So here I have a
Segment, yes.
loop of,
Very
The
good
small
question.
bowel very, very distended in the roundish way, or do you wait until you have an axis to allow the...
you don't look for a perfect target, but
Okay.
the more distended and the more aligned, the better. What is also important is that the tip of the axis is perpendicular to the wall of the small bowel. You don't want to
So,
go
Abed, you can,
tangential
so they
and
cannot
risk
hear us.
pushing the small
So
bowel
in
away.
terms, Dr.
I
Hamad,
think
in
this
terms
is
of,
a very important trick.
So like this, you see, rotate
Yes,
clockwise,
fantastic.
push a little bit in. This is nice alignment.
can you hear us?
So can we put some more fluid? We're waiting to create the distension. Now it's not so nicely aligned, right? So we move it a little bit.
دكتور أندريا
Ahmed, which segment would you prefer for the puncture? Transverse section or longitudinal section? Do you hear us?
Very
Yes.
well.
Okay, which segment would you prefer for puncture, longitudinal or transverse section?
Sorry?
You have distended bowel. Which segment you prefer to puncture? The transverse segment, distended one, or the
The
longitudinal?
one that is close to you
Yes.
with a stable scope.
Yeah.
Okay, we went through.
Good.
It was not perfectly smooth. Can we put the fluid? Can we? No, don't remove it. So, how do I know that my catheter is inside the fluid? I can burn the saline. This is the boiling water.
Yes. Good.
Right?
Very nice.
So this is
Yes.
the saline inside the lumen of the small bowel. I step on the cautery. I see a cloud. I know 100% that I'm inside. So I push all the way. I don't see my catheter. I'm going to see the distal flange when I deploy. So this is distal flange. I pull back, trying to be careful with the friction. Sometimes friction builds in the catheter. And now we put some methylene blue. We didn't start putting methylene blue when we first started injecting, because that methylene blue will be in the ileum. But now the methylene blue is slightly hyperechogenic. Inject, inject. We see some turbulence. So this is the methylene blue coming. And I'm going to deploy the second flange inside the channel of the scope. So we can have some fluoro. Okay? And as I deploy, I keep an eye on the EUS to confirm that the distal flange does not...
Easy.
No, look. Now I've deployed the second flange. It's coming out of the channel. And because, can we move to end of view? So I rotate clockwise my body. I release the stopper, bluish tinge. So
So we,
in
we,
this
we have
case,
some
it's
questions
difficult.
from
Can
here.
you
Can you
remove
hear
the
us?
axios?
So congratulations, Manuel and Andrea. Well done. So just a quick question. So with the recent recall of the three sizes of the Axios, so how are you managing? So what's your strategy for for the GJs especially?
So there's not much to think about because we don't have 20 millimeter axios. So it's only 15 these days. In the beginning, there was only 15. There was no 20 available. So patency seems a little bit better with a 20, but 15 also works very well. And as I said, currently there is no alternative. So you see, this is kind of becoming bluish more than it was. Of course, it gets dilute with all the fluid the patient had. We can also use the fluoro. Maybe if we can put some contrast through the drain, the pigtail end of the drain has come close to the second duodenum. So this is the second, the third, and the tripes. So during adjustment, we dislodge inadvertently. I don't know if there are any other comments or questions.
So just one question was about the size of the nasovaginal catheter. Do you prefer 7 French or 8.5?
Sorry, say that again.
So the size of the nasovaginal catheter, or nasobiliary people call it, but if you're using in jejunum, it's nasovaginal. So what size of the catheter you prefer? 8.5 or 7?
Oh, in our unit, we routinely use 8.5. It allows a higher flow, quicker distension, but it really works also relatively well. So some people say orojejunal, oroduodenal, nasojejunal. We just say parallel enteric tube. We call this the PET assisted method. Thank you.